So this background of mine is supposed to be, living underground in a Mars colony. It's kind of simplistic, but my idea was that the genetically modified humans would be able to live on the surface, and the people like us would maybe have to live underground or have to come right back. Right? That would be the other option. That you wouldn't feel much affection for these radiation resistant children because you'd leave them right away, right? Because can't stay, the radiation is too great. Bye, kids, have a good life, It seems like a very cold sort of thing. Anyway, so I suspect that, let's see if I can share my screen here. All right. So there we go. All right. So, yay, okay. Wow, technology is working. Ethics of the future. So my proposal is that we consider two different questions. One is genetically engineered astronauts and Mars colonists, and the other is the demise of medical specialties and the advent of a new kind of generalist, a kind of meta level. And with both of these things, I think initially there'll be a lot of disconnects and lack of coordination, but eventually we can hope at least be smooth and satisfying and, maybe better than the world of today. So one scenario for Mars then is that the original Mars colonists live underground, but have above ground avatar robots, I've been talking about multiple instances of oneself. So this would be a digital avatar that you controlled and that you could use to interact with people on the surface, whereas it wouldn't be safe for you to actually go there, to interact with your genetically engineered radiation resistant offspring above ground through these avatar robots. And you may know that all the students in the course are getting cardboard cutouts of themselves, sort of going along with this idea of multiple instances of oneself. And more pop music videos also depict that. They never explain why, but the main character divides into many different instances of themselves and with different expressions all at the same time and so on. So this then would be maybe the first instance or the advent of purpose-bred humans. Just a second. Hello. I'm good. Sure, I'd be very happy to do that. I'll tell you something else, that I'm doing a video now, and so that's why I seem a little bit distracted. But no, yeah. So I'll be done with this at 3:30 and be very happy to look after the biopsy. Okay? Okay, thank you. Okay, sorry about that. I'm on call, and so certain things you can't avoid. Okay, so the advent of purpose-bred humans, how can moral objections be overcome? A distinct regime on Mars where different rules apply by mutual consent. Genetically engineered radiation-resistant offspring are born into this culture and so accept it, or maybe there would be instances where they don't accept it. I don't know. And who arbitrates disputes? And then you can imagine that really by Earth rules, human studies of this type of genetic manipulation cannot ethically be done on Earth, particularly on people who are not going to Mars, right? You might say, well, you should try this on other humans first. But I see that as a big challenge that I don't see how that could ever be done ethically. It makes more sense to make these alterations somebody that you're sure is going to Mars, right? But to find out what other effects these genetic alterations would have in other species, including primates, but it seems to me it would be very, very difficult to do like any sort of trial of this in human beings not going to Mars. Assume primate effects and human effects are the same, but in many other instances, that is clearly not the case. The other issue then is the demise of medical specialties and the rise of new generalists at a meta level, and eventually merging with machines so that the human physician is seamlessly integrated in a system considers all medical problems of the patient holistically with a knowledge base that includes all previous specialties and has decision-making and innovation capabilities, creativity, greatly superior to what a human would be capable of on their own. However, to the human physician participating, every challenge is understandable because in some seamless way, the machine intelligence adds to and merges with their own intelligence in a highly efficient and comfortable way, right? We hope. And that is more enjoyable and satisfying than the way medicine is practiced today. And you can guarantee then in that world that no patient would fall between the cracks because they're referred to the wrong specialist, which is something that does happen today. Okay, and in both instances, scenario 1 and 2, one could postulate there would be an initial phase where it's clunky, uncoordinated, frustrating, and morally questionable. But then gradually things would smooth out, become seamless and morally satisfying for all. At least that would be the utopian outcome, I'm thinking. Okay, so that's my introduction, and now I will stop sharing and we'll go on to Insoo's presentation.
Great, thank you. Well, it's nice to be here. I hope you can see my full screen.
Yes.
First slide. Okay, great. Yeah, so I'm going to respond to some of the thoughts that were put out there just now. My name is Insoo Hyun. I have a PhD in philosophy, so I come from a humanities background. I'm the Director of Research Ethics, and I'm a faculty member in the Center for Bioethics at Harvard Medical School. I'm also Professor of Bioethics and Philosophy at Case Western Reserve School of Medicine. So I'm going to give you some thoughts. This is just from one bioethicist. Other bioethicists may disagree with me, but some thoughts about the two scenarios that were just painted for you. I want to begin by reminding us about the pace of biomedical research and the pace of the bioengineering of humans, which thus far, as the bioengineering of living humans goes, has been very, very minimal. The pace in these two areas is rather slow. You know that I'm sure you've already talked about in non-biological technology, there are concepts like the technological singularity, exponential change, and Moore's law. And these are very, very enticing, very provocative theories and claims. But the question is, how well do these concepts and these predictions apply to the world of biomedical research and bioengineering of humans? I'm going to suggest that in that realm, there are plenty of speed bumps, and if you know racing, chicanes, which are these like serpentine-like patterns on the racetrack to slow cars down. There are plenty of speed bumps, both, I wish to say, in the biological sense, in the facts of human reproduction, and then in the regulatory sphere for this kind of biomedical and engineering research activity with living cells and humans and gametes and such. Okay, so I think unlike computers, computer chips, or non-living technology, which I think is completely subject to Moore's law and these other very interesting phenomena of the pace of change, because we're talking about non-living matter, engineered matter, we are really constrained naturally by biological time clocks. In development and biology, we really can't speed things up. You have to wait for generations of animal models to be generated and propagate and bred and brought to life and go through the life cycle. So we're sort of constrained already by the, I would call the clock of biology. You really can't rush an embryo any faster than it can naturally develop. Okay, now, of course, timing of embryo development for the mouse is very fast compared to human, and human is very fast compared to elephant. But every species has its own time scale. So we have that. We have also the problem of, in the case of human alteration, having to go through multiple generations for a lot of these effects to take place. Now, in the case of breeding mice or fruit flies, that happens very quickly, right? You can create new strains of these animal models or fly models very quickly because the turnover rate's very fast. Not for non-human primates, not for human beings. Reproduction takes a long time. Maturity and sexual maturity takes a long time. So there's another sense in which there's a biological speed bump or chicane to kind of like slow down the speed of progress. And then the third area that I think kind of has another sort of, slows down the time of progress is regulation. It's the kind of stuff that I do and some of my colleagues in bioethics do. We deal with coming up with policies that kind of, I think more incrementally than a lot of people would like, advance science step by step. So you wouldn't jump immediately from going from like, a pretty astonishing genome editing study using mice directly to human. You would have to go through a lot of regulatory steps to even do that first in human trial. And right now there's no, within the scope of legitimate regulation and oversight. I know that there were the two Chinese twin babies that were born a couple of years ago of genome editing, but setting aside the rogue actors, in the realm of, quote unquote, more legitimate mainstream science, the pace of advancement for human modification is extremely slow. And a lot of that is in part because of regulation. Now, that said, I do have to then scale back a little bit of what I just said about the pace of science, because it is true that stem cell-based bioengineering is going very quickly. So on the one hand, right, when we're talking about entire organisms and living human beings and new lives, the pace of that kind of modification is very slow. But when it comes to like actually engineering tissue models and other entities in the lab, the pace is actually rather quick. I mean, 1998 was when the first human embryonic stem cell lines were isolated in Wisconsin, expanded into culture. And from 1998 to now we have induced pluripotent stem cells, which are embryonic-like stem cells. You can create any kind of somatic cell from any person, patient, or healthy. And from these pluripotent or embryonic-like cells that you reprogram, you can generate all sorts of really interesting mini organ-like systems that recapitulate very early human development. So what we have here are, brain organoids, that's A, you have liver organoid, that's B, and you have gut organoid. There are many other different organoids that recapitulate human development. But I should point out, each of these organoid models still follows the biological timeline. So if you want to get a mature, relatively mature human brain organoid, it takes at least 9 months. It goes through gestational time. So do the other organoid models. They go through fetal stages and then get more mature if you can supposedly keep them alive for a year or 2 years. Okay, so even in the laboratory in these stem cell-based models, biological time dictates the pace. Another very rapidly moving area is embryo models. So you can get human stem cells, put them in culture, either 2 dimensions or 3 dimensions, and then give them just a few signals to nudge them along, like a bone growth morphogen factor, BMP. And what that does then is it starts to then allow the cells to self-organize into the early stages of embryo development. Now, this is an interesting model because you can actually try to study human development in a dish up to right around the day 14 mark, post-fertilization. And you can edit these cells genetically to see what effects different cells have on development. I should point out, I forgot to mention that regarding organoids, there are groups that want to study, and they are planning to study the growth of, for example, brain organoids and other organoids at the International Space Station. So these are organoids in space. They want to see, in a micro or zero gravity environment, what happens to human development. If somebody gets pregnant and a baby is born on the way to Mars, during that timeline, will it develop normally? You can do, I would imagine, embryo models in space to see in a zero or microgravity environment what happens to the development of all the different tissue systems and organ systems, because it's presumed that these systems evolve to develop in the womb on Earth under earthly conditions. So there's a lot of really interesting activity happening now. The stem cell models are going very quickly, but again, this is very far away from constructing an entire person from these different components. We don't even know if you can take these embryo models in a dish and then transfer them into the womb, and if they would create a baby. Right now, people don't know how to sync up the timing of the uterus and the embryo model, because these are post-implantation stage models, how you would actually get the uterus prepared to accept something like this. I don't think we're anywhere close to that yet. So biological limitations, developmental clock limitations, and then of course regulation. Regulation would say nobody can lawfully transfer any of these constructs into a human body without FDA approval, and FDA is nowhere near giving approval. So on Earth, under earthly ethics, the development of these kinds of technologies for radical human modification are far away. There are other ethical considerations, I think, that the scenario of the Mars colonization really, I think, provokes in my mind. And one is sort of the question of self-determination or individual autonomy over, choices about your own body or about your lineage, your future descendants. You have to make a distinction between someone's right to make decisions to modify oneself, one's own body, versus the modification of one's own descendants. So not one's own body, but maybe your sex cells or the embryo in the dish before gestation. And those are two different kinds of questions. I mean, clearly people have a right to autonomy to modify oneself as an adult. People get tattoos, people have elective surgeries, people do all kinds of things to themselves. They enter clinical trials, but it's an entirely other issue of how far that right to self-determination reaches into the future to your descendants, and can you make choices that really kind of push the boundaries of what may be acceptable risk for people down the road from you. I think closely related to that is the kind of enhancement we might be thinking about for resistance to radiation on Mars, for example. It really gets to the enhancement versus treatment distinction. On Mars, that kind of modification would actually be a treatment. It would be kind of like to prevent you from getting any sicker or to prevent disease. Whereas if you were to do that intervention on Earth before going to Mars, and that would be an enhancement. It gets you above typical species functioning for your environment. So where the modification happens, whether it's an enhancement or treatment, sort of depends on the context of where that modification happens. So that's something also to keep in mind. Why am I bringing this up? Because in research regulation at the FDA level, for example, FDA will approve clinical trials for even rather radical interventions only if it's under a medicalized framework, only if it's under kind of justified as a treatment for something that's ailing folks now. They would not allow for clinical trials something that would take a perfectly healthy person and enhance them above normal. There's no medical rationale for doing such a thing. So the other barrier, in terms of slowing down the clock of progress in this area on Earth, is really this distinction. If it's thought to take you above typical species functioning, then you're really not meeting a medical need, but you are taking them, beyond current capacity. Now, there is a blurriness here to the fact that, like, what about immunizations? Because those are going to take you above species typical functioning, and those are thought to be perfectly acceptable. And in fact, there's research now on the COVID vaccine, right? So I do admit that there is a little bit of a blurry border between enhancement and treatment, because clearly there are certain things like immunizations that would be considered an enhancement, but it's medically justified. And the FDA certainly does approve those kinds of clinical trials. But I think in terms of radiation resistance, and people have also said this about germline genome editing for cancer resistance, for example, where would that fall under FDA? Because you would take a perfectly healthy, normal embryo and you try to introduce, cancer resistance genes, kind of along the lines, I think, in principle of like, radiation resistance genes, if you could ever figure out what those are. Yeah, I mean, that's actually a pretty interesting discussion that people may start to have now, because that would be the only kind of advantage that germline editing would have over current uses of embryo screening for disease. Currently, we have ways to screen embryos that have genetic disorders to prevent implantation of this affected embryo. So the only real advantage right now that germline genome editing has would be to introduce things that the human gene population just doesn't have yet, rather than to screen out things that are harmful, which you can right now do with PGD. The other question is when is this modification happening? Is it happening on Earth prior to going to Mars? I don't think that's, again, for the reasons I just stated, going to be very likely, because that you would have to identify the people who want to go, who are qualified to go, and somehow do a modification that's significant enough prior to their trip. I just don't know if the timeline would match up, and even if you could do like a body-wide somatic cell genetic modification to get everything prepared. I think what's more likely is once you're on Mars, what you would have to do is modify, if the idea is to modify genetically humans there, you would have to do that to future generations on Mars. So I think that the scenario that was painted with, the first colonizers underground and then others, maybe later being able to go more above ground is much more likely, because I just can't see how you could do that intervention beforehand and make it even effective, because it has to be a change done very early in embryo development to affect all the cells. And I just don't see how that could happen with an adult. But that raises in my mind, is this really this kind of genetic modification, assuming that we know what genes to modify and how in the far future, is that really the least burdensome option? Because we might think of other technological means of protecting people against radiation near Mars' surface that doesn't involve anything close to genetic modification, but it's more external, like exosuits or other things, or have a bubble above the city. I mean, there could be other less burdensome, less, for some people, problematic or troublesome options. So whenever you're thinking of a possible future, one thing you might want to keep in mind is, for the ethics of that weighing of costs and benefits, is what's the least burdensome path forward, and that's probably going to be the one that's going to be the most ethically justified. So I just want to just close by just saying a few things about medical specialties. I think that we're actually, where I think that the Mars colonization and human modification is very far off, and I think it probably all have to pretty much be done on Mars, and then compared to genetic modification versus other routes for protection. This area, I think, is much closer to reality. This is something that we're already talking about in the bioethical and biomedical realm, because these kinds of partnerships or new developments in medical practice are happening. They involve technologies that actually do follow Moore's law and these other principles, because these are non-living, machine-based, computer-based, silicon chip-based things are not things that follow biological clocks. These are things that can be manufactured at scale. So this is something that I think very, very much on people's radar now. But then what I think we need to keep in mind is in the realm of medical ethics and medical professionalism, a central component of that is the doctor-patient relationship. It's not simply a matter of to be a good doctor and provide good medical practice, simply a matter of, you know, getting people to the right specialists or getting people to the right doctors and getting the right interventions, but rather having that shared decision-making between the doctor and the patient. So in this country and in most countries, you need informed consent from the patient to do anything to them or for them, anything significant beyond just routine checkups. And for that kind of, you know, complex intervention, you have to have a model of shared decision-making. So this is in contemporary medical ethics and the way it's taught in medical schools like Harvard Medical School. You know, it's thought to be an ideal of shared medical decision-making. And shared medical decision-making is complex. It's not just a simple-minded formula of the doctor brings his or her technical expertise and then the patient brings his or her own values and priorities, and then you just put the two together. It's much more complex than that because the doctor also brings plenty of value judgments along with him or her to the encounter. And the patient also has lots of other technical information about, you know, kind of how they live their lives at home. So you have to bring both technical and value propositions together from both sides. So it's much more complex than just the machines will help doctors better access technical information, and then the patients will help guide that information to best fit their values. It's not that simple. I think there's plenty of value laid in decision making and judgment being done on the doctor's part. It's not just pure technical knowledge and just downloading, you know, information and presenting it to the patient. So so if you're going to have any kind of machine-based AI, you know, assisted medical practice in the future, and by the way, I would even extend that to robot surgeries. You know, you probably want to have ophthalmic surgery or cardiac surgery probably done by a robot, because a robot's going to be a lot more accurate than a human being will be, especially after a long shift. You don't want to be in that doctor's hands. I think that you know, machines and machine learning, that's going to take over a lot of current medical practice. So there's a lot to what was being proposed about, you know, the demise of specialties, and et cetera. But you know, I think that will raise additional ethical questions in the future that we're just maybe not quite aware of yet. And so I think this whole idea of thinking about ethics of the future, or ethics for the future, is an enticing and very important exercise to go through. So that's all I have. I'm going to end here. Thank you, and that's my contact info if you have any questions. And that's it.
Okay, thank you very much. We now go on to Michael Van Manen, who's our local ethics expert.
Sorry, I'm just not as fast with my PowerPoint, so 1 second.
Yeah.
Slideshow.
Cool.
Can you see my slides all right?
Yeah, we can.
Okay. So thank you, Kim, for having me also in this class.
Sorry to interrupt. We see your presenter's view, not the...
All right, 1 sec. View. Show. How's that?
That's much better. Yeah.
Perfect. Sorry, every time I have an external display hooked up, it somehow goes a little wonky. So as Kim said, my name is Michael Van Manen. I'm the director of the John Dossler Health Ethics Center here at the University of Alberta. And I'm also a practicing physician in newborn intensive care at the Stoller Children's Hospital. So this first question, to be honest, when I got the email from Kim and I read this, I'm like, oh my goodness, this is so far and distant away from any of my daily practice or how I think about ethics. It really seems like something on the outer limits, right? As far as whether it's really going to be present or not, as far as a future ethical question. But if we turn to the topic and we actually ask the question, well, what's enclosed within this topic? So what do we mean by ethics? And what do we mean by genetic engineering of human beings? Then I actually don't think we're that distant. So this is an image of the kind of patient that I take care of in the NICU. It's a baby born at around 22, 23 weeks gestation. You can see the eyes are still fused. The skin is very gelatinous, thin and shiny. And if we speak about ethics, this image I'm hoping provokes an ethical response, because we find ourselves possibly wondering, what might this life be like for this young child? What would life be like for parents who are faced with the situation of having to take care of this child? And returning to this question of genetically engineering human beings, what would our ethics or our responsivity be towards these future human beings who are essentially being purposefully bred? Would we regard them in the same way as potentially being fragile? And when we talk about genetically engineering, I would argue that we are already genetically engineering human beings, despite all the regulatory issues that were mentioned previously. When we consider that there are genetic environmental interactions, and when we take care of children before they are supposed to be born, meaning when they're born preterm, inadvertently we actually affect the genetic expression and induce various modifications. So this isn't that distant. I wanted to read a brief anecdote just to kind of point towards these ethics. When she developed contractions at 24 weeks gestation, the sensation was completely foreign to her. It was her first pregnancy. She did not know what it was, perhaps something she ate, a bladder infection or something else. The idea that it might be labor did not even enter her mind. It was only when her water broke in the earliest hours of the morning that she realized she had to get to the hospital. On arriving, there was no time for conversations with specialists about what to do. Doctors, nurses, and others filled the room. Cody was born. He appeared small and scrawny, weighing slightly less than 600 grams. They surrounded him in a flurry of orchestrated medical actions and placed him on a radiant warmer. She could not see what was going on as they initiated resuscitation, supporting his breathing with a face mask. She could not see them inserting a breathing tube to assist with the inflation of his immature lungs. She could not see them insert long intravenous lines into his belly button for administration of fluids and medications. She could only tell that they were working on him as the medical team sequestered him from sight. And then as quickly as the team arrived, they were gone. They had taken him away with hurried, placating words. We are bringing him to the newborn intensive care unit, the NICU. He seems to be doing okay. A couple hours later, Cody's mother had recovered enough to come to the neonatal intensive care unit to see him. He'd been placed in an incubator. The nurse encouraged her to lay a hand on his body, which was adorned with probes, wires, and intravenous lines. His skin was sticky, shiny, and glistening, almost to the point of being translucent. His hands and tiny fingers were delicately flexed into small fists, quivering ever so slightly in response to her touch. His mouth was spread, fixed open by the breathing tube. His eyes were not visible, still fused closed from immaturity. She sensed he felt her presence. His smooth facial features wrinkled in response to her touch. She could not find words to respond to his expression, but she recognized his need for soothing. And then the doctor came, sitting down with her at the bedside. After some talk, the conversation came to a choice: to continue on with medical treatments or to stop. The doctor said it was her decision, a choice they would have liked to have discussed in advance of the medical interventions already done, given the burden of intensive care and the risks of complications or death. Such conversations had not been possible given Cody's precipitous delivery. She stared at Cody. This is not what she would have ever wanted for her child. But in seeing him and touching him, she knew that she did not have a choice. I'm reading that anecdote, which is actually from this book that's in press right now, because to me, this points to the ethics of neonatology, of how we find ourselves responsible for children, what changes before they're born, around the time of birth, and as we begin using various medical technologies to support them, to keep them alive. Which in many ways is actually the same kind of ethics that it's expressed in this question of genetically engineering humans to go to Mars. But the difference is I don't have a concrete anecdote from potentially a parent of what that would be like to genetically engineer their child who they're expecting to be born. I don't have any anecdotes to share of what it might be like to be healthcare professionals or other members of society caring for such individuals. Nor do I have anecdotes from these potential future human beings that they could share with us. So from such a perspective, this ethics of genetically engineering human beings to go to Mars, it's still wide open. I'm pointing to ethics in this way because this is how I understand ethics. So ethics understood as that's what's situated in the encounter with someone or something that's other to ourselves. This is the ethical moment, right? And as the French philosopher writes, Manuel Levinas writes about ethics, ethics is an optics. It's a vision without image, bereft of the synoptic and totalizing objectifying virtues of vision, a relation of an intentionality of a wholly different type. And intentionality here is taken from the phenomenological continental philosophy tradition, meaning directedness, how we find ourselves and things within the world presented to us in our subjectivity. And of course, modern philosophers of technology like Don Idy would describe that all of our intentionalities are mediated by technologies, or Peter Paul Verbeek would say the same thing. And at the same time, this understanding of ethics, which is situated in the encounter, still relates to the moral. So from Wittgenstein's lecture on ethics, ethics can be understood as the inquiry into what is valuable or into what is really important, the inquiry into the meaning of life or into what makes life worth living or in the right way of living. So I put up this picture of Ruth Bader Ginsburg, right, our Supreme Court judge who just passed away this past week, because very much right now we're focusing on the morality and the moral issues that are coming to the forefront, right? More issues around morality are embedded within society and a culture. So how will our society and our culture change in the coming years to decide what is or what is not morally acceptable? That's actually a different kind of question to an ethical question, right? You know, it may be that abortion is no longer considered acceptable in the coming years in the United States, right? That isn't necessarily an ethical question if you consider ethics as how is it that we find ourselves confronted or responsible for a child before they're born? Those are actually two distinct orientations, and we tend to conflate the two. I'm sure some of you are watching this right now on Netflix, Raised by Wolves, right? And there's this beautiful little scene in must be the opening 10 or 15 minutes, where, you know, the little embryos are essentially being taken out of this liquid bath of ventilation and laid onto a table side by side, right? And what's fascinating is this android mother that is taking care of these children is given, maybe it's not fascinating, but she's given this human subjectivity. So even though she's an android, she still relates to her children as a mother, right? And there still is this sense of responsibility I think we have that sense of, particularly when one of them is about to pass and then she wants to hold that child. What's interesting when we begin future thinking, if we're starting to talk about different technologies configuring into the subjective relation, is it fair to reduce an artificial intelligence subjectivity to one that's human, or might it be altogether other than what we can possibly imagine? So these are actually ethical questions that need to be asked related to this scenario. How are humans given to one another when they become a means for space exploration? When they are reduced to a means, right? A way of colonization. That's an ethical question, right? What genetic metabolic differences are distinguished? What possibilities exist for a new eugenics if we're talking about genetic, not just modification, not just genetic treatment, but we're talking about enhancement. That's been alluded to before. How might our societal responsibilities to one another change when a new classism is born between people who are resistant and aren't resistant? How are we present to each other in the dawn of a singularity? I know this is a concept that comes back and forth in this class. What ethics will come into existence when a new singularity is born? If this is this moment in our history of technological development where we can't turn backwards, how radical do we have to we imagine this new subjectivity? So how can we anticipate or understand the subjectivity of a singularity? So these, to me, when we're talking about the ethics of this, it's in part trying to open up new questions that we might not otherwise have thought of, right? Trying to approach this relationship with these modified human beings in a way that we might not otherwise have seen. And that's the value of ethics here. I didn't really have time in this 10 minutes to talk about the demise of medical specialties. You know, this is the kind of image that I often show my trainees when I talk about taking care of babies, right? And trainees love it because it's basically showing this parent encountering their child. And then I remind them in the intensive care unit where we work that there are all these technologies around a parent. Everything from monitors to breathing machines to ECMO machines, for, you know, putting kids on heart-lung bypass if their hearts don't function adequately. Already our new medical professional embodies technologies throughout their day-to-day life. So this isn't something that isn't already happening. We're already changing. I think the question becomes, are we going to be seeing the demise of medical specialties, or are we going to see basically new medical specialties being created, just as we have new technologies? Because when we look back at the history of medicine, the reason that we developed specialties is because we were successful in treatment, because we developed actual means of curing and treating illness, which were technologies. So as new technologies come to the forefront, I think it would be a mistake to assume that we're going to have a demise. I think we'll probably see new specialties coming into existence. So with that, that's all I had, so I'll stop sharing.
Okay, great. So now Shawna Pandya will take us through her thoughts.
Perfect. So I'm just going to share my screen here. Thank you very much to Insoo and Michael for some really thought-provoking thoughts to really get the discussion going. Let me just load my presentation here. Okay. So you guys have been subjected to me for the last 3 lectures, and hopefully I've imparted some wisdom on you. And this lecture is really meant to be about you fostering and spurring the discussion. So rather than, I have 5 minutes, and really I wanted to frame the discussion for you. And like Michael was saying, you know, these are daunting topics, and I'm glad to hear that he said he was daunted about the space topic, because I was daunted about the fall of the specialist topic. And just before I get into these slides, that was an emotional roller coaster going through what goes on in the NICU. And having been on the preterm labor and obstetrical management side, we run into, having the discussion with the patient of what to do for transfer of care if you are dilated and about to deliver at 24 weeks. We know the medical implications. We know what kind of medical comorbidities and chronic disease those kiddos might be faced with. But on the flip side, although it's an N of one and it's an anecdote, one of the brightest residents, who is now a surgeon, that I've ever worked with was a preemie at 26 weeks. So, that's it. These discussions are so hard to have, but let's frame the discussion and give you guys a framework to decide how we can bridge these questions. So to summarize, genetic modifications for sending humans to Mars, yay or nay? And how do we as physicians integrate with technology going forward? And how does that change our role? So I'm just going to recap all of this in the next 5 minutes and then turn it over to you. So let's start with guiding principles. Whenever I'm working in the ER or in clinic, what helps me with my decision making is patient care first. Am I doing right by my patient? There's times, as I think it was Insoo who was saying that, you don't want tired doctors. And I was laughing when he said that, because that was literally me at midnight last night. I'd finished 72 hours of call and was falling asleep while writing emails. And so there's times when you're exhausted as a doctor and you just think, I don't want to. You're just tired. And then that Jiminy Cricket voice comes in your head and says, am I doing right by my patient? And you might drag your feet, but I will always go back to the ER and do that extra little step. So that's one of the guiding principles I use to frame my own practice. Then let's look at guiding principles of medical ethics. So you may have heard of these and you may have come across these before. And honestly, I would defer to Michael and Insoo for further framing these. But briefly, these are non-maleficence, do no harm, beneficence, act in the best interest of your patient, justice, that relates more to equal distribution of resources, and autonomy, respecting your patient's ability to make decisions for themselves. Which brings us to the third point, principles of informed consent. How do we inform someone, and how do we give them, how do we trust that they are making the best possible decision? Well, when it comes to medicine, we have to tell them the risks of the procedure, the benefits, the side effects, and the alternatives. And for me, anytime I'm performing a procedure, whether that's a simple IUD insertion or a cyst removal, I always have to go over these with the patient, letting them know, what happens if we don't act on this, what their other alternatives are, such as watch and wait, or find a different birth control method versus the risks and benefits, such as infection and bleeding. And then once they've been given an informed explanation, do they have the capacity to make that decision for themselves? So that actually also translates into space medicine, as well as in commercial space. So I briefly touched on commercial space in my space medicine lecture, but just to recap, commercial space is looking at providers like Virgin Galactic, Blue Origin, SpaceX, Virgin Galactic saying, so safe your grandmother can fly. And the current framework in the US amongst the FAA for space flight participants to fly is they have to be given the ability to make an informed decision. But where this becomes a bit challenging is we're still trying to define our knowns, our unknowns, and figure out what the unknown unknowns are. So even when we talk about legality, liability, risk, and informed consent within the commercial space sector, it becomes very tricky. And it's not even a lecture unto itself. It's probably a whole PhD topic unto itself. So to wrap up in the next 2 minutes here, we talked a lot about the issues of reproduction and development in space. I touched on it super briefly last time. I did want to point you to a recent podcast that I had done on the future of sex podcast that looks exactly at the ethical issues that Insoo and Michael had discussed. So we chatted about the 5 big risks when it comes to sending humans beyond low Earth orbit on exploration class missions. So we talked about altered gravity environments, distance from Earth, radiation, isolation confinements, and hostile environments. And we concluded that space is trying to kill us. So what is our duty then to do right by our patients, in this case, the astronaut? And what happens when we start venturing into brand new territory? So say that we have somehow solved the radiation problem and we've sent a mixed gender crew to Mars, and there's 6 people, 4 males, 2 females, and you suddenly notice that 1 male and 1 female happen to be slipping off very frequently. And when they come back, they're flushed, sweaty, a little bit giggly, a little bit sheepish. And before long, the female astronaut complains about being tired, nauseous, just unable to perform her duties. And then sure enough, you check and she's pregnant. So then what become your considerations with respect to, I'm just gonna go to that slide, your duty to inform stakeholders? If this is a NASA-funded mission, do you have to inform the taxpayers? What is your duty towards continuing the pregnancy? Can you mandate termination of pregnancy? Do you have to end the mission? How does that impact the crew? Is it even possible to end the mission early, given how hard it is to coordinate transport to and from Mars? What happens to the rest of the crew's duties and utilization of resources? Because now you have 5 people covering the duty of the 6th, as well as you're also spending your crew atmosphere, your life support systems, your water, and your food on a 7th crew member. What are the risks? Is it deemed too medically risky to continue with that pregnancy in space if you've previously never done conducted the proper studies? So you might have remembered from the last lecture, I briefly went over all of what we know from animal, insect, jellyfish studies, zebrafish studies in space. And at best, we conclude that further study is needed. We just don't know what happens from intercourse to conception to development. The data is mixed at best. It's conflicting and further studies are needed. At worst, that development in 0G at least is a non-starter. So I'm going to leave it at that because I think I'm far beyond my 5 minutes. So then briefly to talk about the rise of the generalist and the fall of the specialist. I just really want to give you this framework for the discussion that you'll lead in the last part of this class is what makes a doctor? When we talk about training doctors in Canada, we talk about the CanMed's medical competence. What makes an expert? And part of that is being a leader, a collaborator, and an advocate. So essentially, your job is to be a manager of health information in your patient. So in that case, do you argue that you have an ethical duty to integrate with technologies make you a better, more competent physician and a better manager? On the flip side, if you err in the direction of completely autonomous technology, we talked about surgical robotics and master-slave relationships at present versus completely autonomous surgical robotics. In the event of a HAL 9000 scenario, who is held liable? So remember, first, do no harm. Here are the guiding principles that I would say guide my medical practice, as well as ethical quandaries like sex in space, future settlements on Mars. And with that, I will turn it over to you guys for discussion.
Okay, great. Yeah, 3 wonderful presentations. So, questions?
How far are we from being able to develop these radiation-resistant humans. I mean, it's good to think about, you know, if they would have feelings and the ethics of this from now on, but are we going to see this in our lifetime?
Sure, I can answer that. That's a really good question. It's in its infancy so far. So you might have remembered in the space medicine lecture, so 2 lectures ago, I talked about the MIT review article that talked about engineering the perfect astronaut. And right now they're very much in the in vitro phase. So they're talking about splicing elephant genes with a banana, which is a far cry from splicing elephant genes into you or me. So we have 4 copies of a oncogene or a cancer editing gene. So we, you know, it's experimental. It's being done in very, very, very early laboratory stages right now. But on the flip side is even if we had the technology today, go through the thought experiment. And I would turn the question to all of you is, are we ready as a society? You know, down south, I think Michael pointed out that we may be regressing to rescind Roe v. Wade, depending on what happens with the Supreme Court. So, you know, if we had the capability today, from a societal perspective, would we be ready to accept that? And if not, what would need to change and how would it need to change to be able to accept that?
Other questions?
I don't know if anyone wanted to, but I wanted to follow up with that. Because right now it's very, very hard to come to a consensus because each country has their own vision of what's right and what's wrong. And many times they do clash. So should we create a worldwide society, and would that facilitate things going on?
Well, you know, in a way, as far as like genome editing goes, there is kind of, I think, generally thought to be a worldwide consensus, at least among the partners that are pretty active in this field. So recently, just like a couple of weeks ago, a final report was issued by the National Academy of Sciences in the US, the Royal Society in the UK, and the Chinese Academy of Sciences. So UK, US, China, those are countries that are very active in genome editing research. And the consensus there of that report of these 3 big commissions was that we're not anywhere near prime time or application for humans for reproductive use. So I don't think that we have to go so far as to have like consensus on all other cultural issues, but when it comes to particular technologies, scientific bodies in different countries already have issued statements where there's pretty good consensus on this issue. So how far are we away from, you know, again, radiation resistant humans? It would have to, you would have to do it either somatic cell or germline modification. I don't think somatic cell would work. So just, you'd have to modify every cell in the human body through CRISPR, and I just don't see that happening. So it would have to be done at a germline level, at sperm, egg, or 1 cell embryo, or even, you know, a couple cells. And on the germline editing to make a baby, as I just said, the consensus has been in these 3 societies that we're not ready, and that there needs to be more social dialogue. So there hasn't even been research along this lines, other than just a little bit of tinkering around with a few remaining embryos here and there, a lot of it from China. But yeah, I mean, we haven't, I don't think there's an idea that people are ready to go ahead for actual reproductive use at this time. So we're talking about years and years.
Yeah. Yeah, so I just wanted to briefly mention the relevance of the concept that you just talked about, Insoo, to mind uploading and the timing of mind uploading. So Ray Kurzweil says that in 19 years, in the 2030s, mind uploading will be successful and widespread, and you know, lots of people will be doing it. And I think it's going to take 10 times longer. So it I say 193 years versus 19 years. Not because the technology won't be there at 19 years, but the average human being on this planet has not spent a single second thinking of what it would be like to be a, digital upload, to be, immortal, but not have the substance of, biology that we're used to. And so we're just not ready. And I think we won't be ready for a long time. So, and that's just as important is whether we can do something, right? I mean, it is interesting to think, well, when will we be able to do mind uploading? But even more important is when will society be ready? And I think that will take a long time. And you've probably seen my video with my 7-year-old granddaughter. You know, or you may know that I've talked a lot about the age of 27. Many famous people, their most quoted statements or something they said at the age of 27. Well, if Kurzweil is right, then my granddaughter could upload her consciousness to a ceramic slab at the age of 26 and be communicating with thoughts, and she wouldn't need to speak English any longer because you can directly communicate. And so all those great statements she could have said at the age of 27 will never happen,
Kim, I haven't read Kurzweil's arguments about why he thinks we're kind of on the brink of this. So I can't speak specifically to his proposal, but a few things come to mind that I think complicate the matter even further. So here's one. So we don't know. So I'm doing research with brain organoid researchers, and in that space, people start to worry about at what point, if ever, will brain organoids in the lab after 1 or 2 years ever develop consciousness, because we know neonatal, brains eventually become infants, and infants become conscious. So nobody knows there's so many different meanings of the word consciousness, and nobody really knows how you reproduce it in the organoid lab. So we're much closer to something like that, because that's all biologically based, and we're just tracking brain development. We don't know how you would actually, if you wanted to, develop a protocol where you would make these things conscious, to even know what the biological substrates are, to then know what it is you would be transferring over to a non-biological state. So there's not even like an agreement about what it is that we're trying to transfer over. So that's one problem. The other one is kind of, you mentioned your granddaughter, and I thought that's this is what made me think about the other issue, which is presumably you can take one brain and then you don't have to just transfer it into one substrate, it could be many. Right?
Yeah.
You can be like 5 of
thousands,
these.
yes.
Thousands. Well, then you have a personal identity problem, right? Because you have one person that gets split into multiple consciousnesses, and then from that point on, they all kind of get their new experiences, and they become different people additively over time. So how could you even say that in the one transfer, the same person's gone on and survives the procedure? So there's that whole a personal identity issue as well, because personal identity is unitary, it can't be divided, but these technologies will allow multiple divisions. And then furthermore, once you actually transfer it, and there's kind of like the experience of being yourself somehow survives the procedure, there still needs to be input, there still needs to be other sources of experience for that consciousness to carry forward. And I don't, if it's outside the human body, then whatever inputs those are going to be very different in nature. So for me anyway, I would feel like, after just a few seconds of that transfer, I feel like I'm effectively dead, because the experience is just so different. I might as well be in heaven. I might as well be somewhere else. Why I think I survived that procedure. So those are just some thoughts that I had just hearing your
Right.
your
No,
issue.
I think that you're right, that it is a bit like being dead. But the other side of it, which would be very potent, is if you were the first person that this happened to, the pressure on you to self-report that everything was great and you feel better as a digital upload than you ever felt as a biological being, the pressure would be so great that we couldn't trust what you were telling us. And that's another issue. Michael?
Yeah, I think coming back to the question of, is this something that we're going to see within our lifetime? When you look back at like futurists and, different predictions that they've made 20 years ago, 50 years ago, in hindsight, we can say, oh, it was realized. Their predictions were realized, but maybe not in the exact way that that individual at the time had realized their predictions to come forward. So when we talk about uploading consciousness, we have in our own sense of, well, this is what consciousness is from my subjective sense as a human being. But we have to be prepared for the possibility that what conscious subjectivity might be like for an uploaded is going to be something that's somehow foreign and different from our own subjectivity. And that becomes really interesting, right? Because you're trying to basically approach, from an ethics perspective, you're trying to approach the understanding of what life might be like for another who is somehow different from ourselves, but still is somehow similar, right? And that is, it's fascinating, and probably where we see this done the best and actually cultivating public dialogue, it is in the media, right? So if we want to start talking about upload, yeah, go watch wasn't there a TV show called Upload on Netflix?
Yeah, it's a series. Yeah.
Right, yeah. And recognizing that these, shows can help stir dialogue and conversation and question of, well, what might it be like? But what's challenging, of course, is often after the first episode, the show basically just reverts to, well, being an uploaded consciousness is going to essentially be just not having a body, right? Yet it will still be very much the same existence we carry on in our day-to-day life, with all the same practicalities of my wife or girlfriend is controlling me or some other partner, right? So I do really appreciate your class and how you're trying to imagine possible futures. But there's always that desire of trying to somehow break with our own grasp of what is actually consciousness, what actually is genetic engineering, and so forth.
Yeah. Kaylin Morrison has a question.
Yeah, so kind of coming back to Eduardo's talk about, oh man, what was I going to ask? It was kind of about ethics and how in China and things like that, there have been some genetic modifications, but that the general population of kind of researchers are standardized across the board with saying that more research needs to be done and the social aspect isn't there for doing genetically modified human beings, all that. But what happens in those cases where we can't control what goes on, like in places like China where that already happened, or even more authoritarian regimes?
Yeah, or labs on ships, right? There's the other side, like in international waters, people who feel they're bound by no rules. And maybe on Mars, we'd also be bound by new rules, not necessarily no rules, but maybe not any Earth government's rules.
Yeah.
So just to add some fodder for discussion, to get you guys thinking, this is a 2004-2006, something like that, study from a Florida institution where they created a neural network of 25,000 neurons, and they got it to actually successfully fly a simulator. So conscious or no, and if not, how much further, like what would need to happen for you to define it as consciousness? And I guess to start, how would you define consciousness? Just no, you don't have to answer it now because people spend their entire lives defining this. But check out that link. That's just to add fuel to the fire. And then also coming back to Kaylin's question, when we talk about what's acceptable versus not, I'm not a poli-sci major and I'm not an ethicist, but I like thinking about the Overton window and applying that principle, not just to politics, but to what we accept, what is societally acceptable. So even just stepping away from genetic enhancement, but let's just look at cosmetic enhancement, right? And let's look at the spectrum of what's acceptable versus not, right? On the one end of the spectrum, never bathing, never showering, never brushing your teeth, just wearing the same thing day in, day out. Most people would say, well, I don't think that's acceptable, versus the body modification conferences that go on where people give themselves horns and fork their tongues and tattoo their eyeballs. And I'll spare you, but if you're interested, Google it, right? And then, what we accept as acceptable, as in daily grooming, showering, right? What's acceptable now, and how do we expect that to change? And how has that changed from what we previously accepted in terms of cosmetics and appearances? And, what do we no longer do? And what do we look at the past and say, oh, that was silly, people putting lead drops in their eyes to dilate them, Chinese foot binding, right? We say, oh, they're so silly. But what would people 200 years from now look back at us and say, oh my God, they were so silly? Stilettos, they hurt, but they look great. That's my personal opinion. Some might say, okay, but I think that's something to think about. So leave it there. And then Taryn, I just want to answer your question. You're talking about justice, you're talking about space colonization in the chat here, implications for allocations of resources, and then how do we justify that in talking about problems on Earth versus space? Holy cow, that's a heck of a lot of questions, but good questions. So remember, going back 2 lectures from today, we talked about meeting the gold standard of care, of healthcare that we would provide on Earth as we would in space, and ideally exceeding that, borrowing from concepts in science fiction. Because remember, the ideal would be to just bring another Earth with us, terraform Mars so we can have 1G, have an atmosphere, have Van Allen belts to filter out all that radiation. But then also frame that in the constraints of the backpacking principle, or the Aladdin principle of packing for space, right? That infinite, that itty bitty living space, right? So whatever you bring with you is at the cost of something else. And then translating that to the last part of your question, how would you address that, and allocating all of these resources for space exploration when you have all of these problems on Earth? And what about reframing that as not an either or problem? We briefly talked about, I think we ran out of time, we talked about spin-off and spin-in technologies, and using what we've learned in terms of bone health research, muscle health research on the ISS, and spinning that off for osteoporosis and muscular dystrophy research on Earth. And on the flip side, taking lessons we've learned from resource-limited areas such as Antarctica and the Canadian Antarctic, and spinning those lessons off for space. So the other way to frame that question is, instead of saying, why not solve our problems on Earth, how do we use space to address problems on Earth, and how do we use solutions on Earth to make human space flight easier?
Great. Okay, we have 6 minutes. Ashley.
Okay, I have something to say to both of the kind of topics we've touched on. When it comes to say people who already did, I'm trying to think, like the HIV gene editing stuff that happened, I guess kind of to look at, I think his name was Barry Marshall, who did H. pylori, who I believe pretty much just gave himself an infection to be able to try and prove that he could fix it. He also won a Nobel Prize. He wasn't completely exiled from science because he did that. So it seems almost like the advancements of some of these things are going to be on the backs of people who are willing to risk their job and their whole life kind of to advance this, even though our society and everyone above them is telling them that they're not allowed to do that. because there is someone who gene edited a human now, and it's out there, we think. So that's kind of already happened. And then I was going to talk about prioritizing addressing Earth problems versus space problems. So when it comes to like timing of everything, I think that genetically modifying humans for being radiation resistant, I don't know if that's likely to be the first thing that we look at when we go through genetic engineering like process. So there's probably a lot of other issues that as a society we're going to decide is more important at the beginning. So this may happen later on, but I don't know if this is going to be the earliest thing that happens, because we have a lot of other issues that we're going to try and address first.
One thing that the pandemic has certainly shown us is that the future is harder to predict than we previously thought, and that, you know, there are a lot of things that have actually happened to us that if you had written them as fiction, people would have said, well, that's not a plausible scenario, you know? So we can't really be certain. Like, Elon Musk has taken a lot of ideas that seemed pretty crazy to other people and actually made them practical and operational and things you can make money from and society benefits from. And so the fact that he's pushing this does sort of move the needle a little bit toward its actual happening, as opposed to, as you say, all the barriers that we thought existed before, where, you know, this is like not going to happen for hundreds and hundreds of years. That was the way that we felt about this before. I think the situation has changed a little bit, you know, and so politics, we're finding, this is not something you could just ignore. Yes, Insoo.
Yeah, I wanted to just comment on something Ashley said. So you compare, so you were wondering, you know, so Dr. He in China, who did the genome edited babies, maybe, you know, somebody like that are characterized folks who do move technology and medicine and science forward because they take big risks. I think that probably the better comparison there would be Steptoe and Edwards. Patrick Steptoe and Robert Edwards developed in vitro fertilization in England in 1978. And although Patrick Steptoe passed away and thus couldn't get the Nobel Prize, Edwards got the Nobel Prize in 2010 for his innovation. Now there, people, you know, wonder whether they would have actually passed ethical review today with the kind of work that they were doing. That you know, the in vitro experimentation was so cutting edge and so controversial. Fertilizing an egg outside the human body, culturing it for a few days to implantation stage, and then transferring it. And they had many, many failures, right? So you might say, well, what's the difference between them and, you know, Edwards getting a Nobel Prize and Dr. He? Well, I think a couple of things to say about the He case is that some people just said he didn't technically do what he set out to do. He probably didn't do the ethics correctly, and it was incomplete. So there's a lot of question about his methodology and his actual technical prowess. The other is that he violated Chinese law, because even in China, it was against the law to transfer into the uterus these things, whereas there was no clear law in the UK at that time. So you can argue about how similar or different are the two, but the biggest divider for me is Edwards and Steptoe actually succeeded, and they showed social benefit of their controversial technology. He has not succeeded yet. I don't think he's going to get another shot at it. And maybe somebody who does actually succeed in producing social benefit through germline editing may eventually get something like a Nobel Prize later. That person still hasn't stepped forward. So yeah, you're right. I mean, it does take big moves, like big innovators, big risks, during a time when I'm sure people are having controversy around that procedure. So I just wanted to say, well, you're not completely off the mark in what you're saying about Dr. He, because I think you can say many of the same things for Steptoe and Edwards did get the Nobel Prize. But I think that probably is kind of maybe a useful contrast to kind of dig in further and try to clarify for yourself, you know, and refine the position that you've initially asserted, which was maybe we do need people like this to move science forward.
Right. So we're at 3:20, and we have a kind of tradition of keeping talking, but it is also a guiltless thing that you don't have to apologize if you now leave, because it's an 80-minute class period, and it's over now, right? So we can keep on talking, but don't feel bad if you have to leave. We all understand that, and that includes the speakers that we have who only agreed to speak for 80 minutes and could have something going on in the next 5 minutes entirely different. So anyway, yeah, so let's keep on discussing it. I think this is one of the best sessions that we've ever had in 9 years of the course, and so I would like to do more of this kind of thing. And we have a pretty good mix. This is a good mix of speakers, and it's a very good class. And so both things are in our favor. And the COVID epidemic also helps because people can't leave. Why is Shawna such a presence this year? She doesn't have any choice. She's in Edmonton, So yeah, she is a bigger part of this course than she's ever been before. Yeah.
Well, this is great. Thank you so much for having me. I do have another commitment I have to zoom off to. So
yeah, no,
I will leave it here. It was great meeting everybody.
So
thank you so much for the opportunity.
Yeah, great. Thank you very, very much. Yeah.
Thank you, guys.
Probably not very ethical of me to skip my afternoon clinic in favor of the chat, although it's very, very informative. For those of you who haven't been following the side chat and discussions that have been going on, I encourage you to look. But yeah, Kim, thank you so much for involving me this much this year. Yeah. I had a figurative blast, so yeah, please please reach out with further questions. Happy to answer more offline.
Great. Okay. Thank you, Shawna. Very, very much.
I sadly have to also deal with some clinical responsibilities.
Yeah.
But can I make one comment before I go?
Sure. Yeah.
When Shawna was presenting her slides, she pointed to the principles of kind of medicine. And certainly in medical education, that's the way we tend to teach ethics, right? You abide by these duties or these responsibilities. And if you do so, you're going to be an ethical physician. In that sense, morality, or what is good, is clearly located within the principles themselves. And that's known as deontology. But it's important to point out that where you locate the good, there's different ways of looking at that from an ethics perspective. So there also are utilitarian theories, there are virtue ethics, there's relational ethics, ethics of care and feminism, phenomenological ethics. And all of these kind of locate this notion of what is good differently. And that's what's so challenging about ethics for people who are really passionate about and into it, is you'll never get one answer to any of these questions. People will just keep on talking forever. But that's also the value of ethics, is helping us to kind of reflect on different possibilities, both in our contemporary life, in the past, and in the future. I did give my email. Please feel free to contact me at any time. And also, I hope you all know that you're always welcome to attend any Dossiter Health Ethics seminars. We offer them generally every Thursday or every second Thursday throughout the year.
Great. Okay. Thank you very much, Michael. Thank you, Shawna. Okay, guys. So, any other questions? So I told people on the clinical side that I'd be free at 3:30. So I do have 6 more minutes if there are things that you want to discuss. So did you enjoy this? We hadn't ever done anything exactly like this before. When Insoo and I met, it was apparent that we had very, very different worldviews. And, I have generally been speaking about the future in a setting where most people in the audience already buy into, exponential change and Moore's Law and all that kind of thing. And at that conference, he was describing a very linear future where, do you think that in the future it might be? And then he described some very minor change. Very, very interesting that the prediction is that by that time there'll be, enormous changes. And here you're asking if it's possible that there could be this little tiny change. So that's how we sort of met. But yeah, and his martial arts career, I don't personally know another scientist has advanced so far in martial arts, which is very interesting, and so yeah, that's just another side of him. We all have other sides of ourselves, but it's really cool. Yes, Ashley?
Can I just say, like, throughout this whole thing, I've been like this whole class, like, so far, this course, I've been a little like starstruck because like my celebrities are not, I don't really look at like social media for like celebrities since I want to stay in like the academic world. These type of people are like celebrities to me. So I'm very like overwhelmed in some of these things because all of the people that were on this panel were like, are all in a field that like, especially since I want to go into like reproduction and stuff and neonatology and stuff, like these are all, yeah, is all I have to say. Is this is like, I don't know, very overwhelming.
Well, I just want to point out that it's not over. David Pierce is also a very exciting guy to interact with. He's one of the founders of transhumanism, and I think he's never had a haircut by a trained barber his entire life. So I once asked, I accidentally got in this subject of haircuts and found out, I mean, there are people in this world who just don't believe going to a professional to get your haircut. And he's one of them. And so you are in the future going to meet some really cool people here. And that includes people your own age or younger who will be teaching here too. So yeah. So I pride myself also in making the course different every term. So if you think of new ways to enhance the course or things you would like to see in the future, that is certainly possible. So for instance, if you look at the midterm and this question of doing the midterm as a take home over a weekend, I think that's going to be great. Because it certainly has been a kind of anxiety-provoking thing in the past. And there's always been this time pressure, and that will completely eliminate it. So you guys are a good natural experiment this time for seeing how that goes. There still will be performance effects of, like, if you haven't done any work in the course at all until that weekend, you won't do as well, even if it's completely open book and you can spend the entire weekend, you still won't do as well as somebody who's been kind of studying things and keeping up, right? So, but it'll be a different kind of comparison and not particularly geared to how you are at taking tests in a limited time, because you'll have practically unlimited time. And then some of you may actually spend every waking moment of that weekend on the exam, which is probably also a serious mistake in your personal life, right? I mean, that there's just no way to justify that. So I hope that doesn't happen, but in theory it could. So that'll be very interesting this time. There'll be ways in which the course will be unique the next time and the next time after that, and so on. So. Okay, it's 3:30, so I have to go. Anyway, thank you, and we'll see you on Thursday. Okay, bye-bye. Okay, so we just did probably the most interesting class session that I've ever had at my course. So, anyway, alrighty. And